Diagnosis of hypertension must be accurate, systematic. First, correct blood pressure measurement technique is essential in the clinic. The patient should sit quietly for at least 5 minutes in a calm room. There should be no caffeine, smoking, or exercise for at least 30 minutes before measurement. The back must be supported, feet placed flat on the floor, legs uncrossed, and the arms supported at heart level. A properly sized cuff and a validated blood pressure device must be used. At least 2 blood pressure readings should be taken, 1 to 2 minutes apart, and the average should be recorded. If there is a large difference between readings, additional measurements should be taken, and a stable average of the consistent readings should be used. Hypertension should not be diagnosed on a single visit unless blood pressure is very high or there is evidence of target organ damage. Diagnosis generally requires elevated readings on at least 2 separate occasions. Hypertension is diagnosed when office blood pressure is 140 millimeters of mercury systolic or higher and/or 90 millimeters of mercury diastolic or higher on at least 2 different days. According to American guidelines, normal blood pressure is less than 120 over 80 millimeters of mercury. Elevated blood pressure is systolic between 120 and 129 with diastolic less than 80. Stage 1. Hypertension is systolic 130 to 139 or diastolic 80 to 89. Stage 2 hypertension is systolic 140 or higher or diastolic 90 or higher. Out-of-office blood pressure monitoring is strongly recommended to confirm the diagnosis and to rule out white coat hypertension and masked hypertension. Now, how to correctly perform home blood pressure monitoring. Patients should use a validated automatic upper arm blood pressure monitor. Wrist or finger monitors are not preferred because they are less accurate. Blood pressure should be measured in a quiet environment after resting for 5 minutes. The back should be supported, feet flat on the floor, legs uncrossed, and the arms supported at heart level. Do not talk during the measurement. 2 readings should be taken in the morning before breakfast and medications, and 2 readings in the evening before sleeping, each 1 to 2 minutes apart. This should be continued for at least 5 to 7 days. The first day's readings may be discarded, and the remaining readings are averaged. Home blood pressure is considered high if the average value is 135 over 85 millimeters of mercury or higher. Ambulatory blood pressure monitoring is another important method. It records blood pressure over 24 hours during routine daily activity and sleep. Hypertension is diagnosed if the 24-hour average is 130 over 80 or higher, the daytime average is 135 over 85 or higher, or the nighttime average is 120 over 70 or higher. Normally, our blood pressure is slightly higher during the daytime and decreases while we sleep at night. This natural fall in blood pressure is called the dipping pattern. If blood pressure drops by 10% or more during sleep, it is called a dipper pattern. This is considered normal and healthy. If the nighttime blood pressure drop is less than 10%, it is called a non-dipper pattern. Non-dipper patients have a higher risk of heart disease, stroke, and kidney problems. If blood pressure increases at night instead of decreasing, it is called a reverse dipper pattern. This is the most risky pattern and requires close monitoring and proper medical management. That is why 24-hour ambulatory blood pressure monitoring, or ABPM, is important to identify these patterns and guide the right treatment. Hypertensive emergency occurs when blood pressure is very high, usually systolic blood pressure of 180 millimeters of mercury or higher, and/or diastolic blood pressure of 120 millimeters of mercury or higher, with evidence of acute target organ damage. Examples of target organ damage include hypertensive encephalopathy, stroke or brain hemorrhage, acute heart failure with pulmonary edema, acute coronary syndrome, acute kidney injury with rising creatinine, and retinal hemorrhage or papal edema. This is a life-threatening situation. Hypertensive urgency also involves severely elevated blood pressure. typically 180 over 120 millimeters of mercury or higher, but without any signs of acute target organ damage. Resistant hypertension is diagnosed when blood pressure remains above target levels despite the patient taking 3 different antihypertensive medications at appropriate or maximum tolerated doses, and one of these medicines must be a diuretic. Alternatively, if blood pressure is controlled but requires 4 or more antihypertensive medications, it is also classified as resistant hypertension. Before labeling a patient as resistant hypertensive, we must ensure the diagnosis is correct. Pseudo-resistance must be ruled out, including improper blood pressure measurement technique, poor medication adherence, and white coat hypertension. Secondary causes of hypertension should also be evaluated, such as chronic kidney disease, primary aldosteronism, renovascular disease, obstructive sleep apnea, thyroid disorders, and drug-induced hypertension.